Thank you very much for having me here. Thank you to the organizers. It's always very nice to be every year. I was asked to give a presentation about the neurological manifestations of Ehlers-Danlos syndrome. The very first article about EDS in neurology / neurosurgery was one of the co-authors along with Dr. Mira back in 2007. After a number of years, we were observing more and more patients with this disorder. The latest article, which is kind of summarizing a sort of an encyclopedia way the neurological and spinal manifestation of Ehlers-Danlos, has been published last year. And again, I was lucky to be part of this group. First of all, what's EDS? EDS is a connective tissue disorder, but EDS per se is not a disease. I know that somebody is going to be a little bit startled by that, but EDS per se is an evolutionary advantage. Evolutionary advantage is something which with evolution has popped up as a spontaneous mutation and has stayed in the human race because it gives advantages. Being fast, you outrun the lion, is good. If you camouflage, is good because you save your own rear end. Being flexible is another of these advantages. So per se, it is not a disease. You know, if you remove the EDS from the face of the earth, practically half of the people of the Olympic team of any nation is going to be out. You're not going to have any more cheerleaders. You're not going to have any more dancers. The Rockettes are all going to be gone. Gymnastics team are going to be done by stiffers like me, so it's not going to be the same good world. But sometimes this condition backfires and produces clinical problems. And at that point, it becomes a disease. But EDS per se is not. Once you start having something which, with its own version of flexibility, if you have somebody with EDS, they can do things with their joints, sort of a party tricks that us mortals we cannot do. They can do backflips, they can twist around. So they have their own range of normal. And they should not be evaluated with the same, yardstick we have for us common mortal. So now, at this point, there is a problem. What is hypermobile? What is within the normal range for them? What is hypermobile and it is beyond the normal range for them? And when it is unstable, which means that your instability, your hypermobility has gone rogue, and all of a sudden is a clinical problem for you. Right now, there are no clear-cut ranges for all the measurements we have to define what is frank instability. The Chiari EDS Association was first described in the first article I showed by Mira, Dr. Kula, myself, and others, including Otto Francomano from me. Back then, she was at NIH, and showed a number of features. The standard Chiari malformation is a 3.5 to 1 female-to-male ratio. Once you have Chiari and EDS, the female-to-male ratio goes to 9.5 to 1. And the patients are younger, and the patients tend to be sicker whenever they are made sick by this combination. Obviously, there are a number of patients who are also asymptomatic, but tend to be less in percentage to the people that are Chiari alone. So it's their own disease. There's something like its own little corner. And recent studies from Duke, from the genetic study, has showed that the people with Chiari and people with Chiari EDS have a different genetic makeup. The complex Chiari is a entity which has been described recently. Back in the past, Mira and I were calling it Chiari plus something else. Complex Chiari is a name which was given by Dr. Brockmeyer at the University of Utah. It is Chiari plus a pathology of craniocervical joint. This is a typical complex Chiari. Retroflexodontoid, some thick ligament behind it, and a deep Chiari 1 malformation, and this is 1 plus 1. The association of Chiari and EDS has its own set of complications, which are not exclusive, but tend to be more prevalent in this patient population. The dura is thinner, the dura is more stretchy, and therefore the incidence of cerebrospinal fluid leakage tends to be higher, and so as a surgeon you need to be more careful during closure. And the patients are more prone to post-surgical or pre-surgical craniocervical instability as part of the package, especially if you remove the back of the first vertebra. And then, since the patients with connective tissue disorders have this in common, you have wound healing problems. So your techniques to close the soft tissues have to be modified. How do we find out? The hard way. Epidemiology means, then there is the second point when you have just craniocervical instability alone. Many of you have heard about it, so I'm not going to go long on topics you're familiar with. But in the field of craniocervical instability, the problem is not so much that the joint is deformed. The problem is the joint is normal anatomically the majority of the times, but the rubber bands keeping the joint together, which are the ligaments, are genetically defective and they're too loose. Since they're loosey-goosey, they're creating problems of its own. So what did we find in this patient population? They found the patients are younger. The female-to-male ratio, again here, is higher, like for the Chiari EDS association. There are more lower brainstem in the clinical presentation, and they're in worse clinical shape than not the people with craniocervical instability without EDS. Often they're asymptomatic, but not as often that the other non-EDS counterparts. And this number is important. About 90% of the people who have little or no symptoms with bad morphometrics, which means a CXA or less than 125 degrees and a GRAB or PBC2 more than 9 millimeters, independently if they're young children or adolescent or adults. 90% of them will have surgery, will deteriorate, and end up having surgery within 5 years of the initial diagnosis. This is an anatomy of the joint, looking sagittal. Sagittal means that you pass a chainsaw from the front of the nose to the back of the head. And these are the bones, and you see all these little strings, and the strings are the ligaments. Ligaments are the rubber bands keeping the joint together. You understand that if these ligaments become loose, all these joints start moving too much, like a door with poor hinges. This is another view of the same ligaments seen from a different perspective, towards the back and towards the front. So this is the way that the craniocervical junction looks. This is the base of the skull. It's the so-called condyle that Dr. Rickett showed you this morning. This is the lateral mass of the first vertebra, and this is the second vertebra. And this is just one of the multiple motions that this joint has. This joint can move vertically, horizontally, and in a rotation. So when you have a craniocervical instability, which means that the joint is really falling apart and the patient is sick for it, the best thing we can come out with right now is to fuse it together. So we put screws in the back of the skull and in the back of the spine, and this is the way it looks on an X-ray, and this is the way it looks on a 3D CT. You need bone to reinforce it. Or you can do the technique that Dr. Rickett described this morning with the condylar screws, which is a much shorter device with lesser problems in terms of tolerability and lesser problems in terms of what is called metal fatigue, which means the fusion falling apart later. So what do we want? We want to rectify the retroflexodontoid, we want to stabilize the joint, and to recreate a more physiologic appearance. What we did not know when we started playing with these patients was that we were throwing a known variable to an unknown situation. We were saying, all right, this patient has instability. Oh, we know what to do. We can do the fusion. Trying before is going to work the same. And then we started having eggs on the face because we did not know what EDS was going back to us in terms of curve balls. So besides some of these things on the top left side, which, the hardware evolved, so we had to adapt to that. But there were problems with large craniectomies. So how can you fuse the back of the skull if there is no back of the skull anymore? And fortunately, in 2009, we came up with the condylar screw fixation. The other problem is that the morphometrics, how do you, okay, fine, we have these measurements, we can throw at this to decide what's right, what's wrong, and the shade of gray in between. but these patients had their own range of motion, which is not the range of motion of us mortals. The other one, the surgical criteria had evolved and had to evolve over the years. And then how far south you go, which means in the past we were fusing people down to C4 or C5, and then it became evident that fusing much shorter was going to be a better choice. The other problem is, do we incorporate C1 or not? How do you do the bone fusion? People with EDS have a bad bone metabolism. So if you throw in the usual ingredients, which usually end up having a good bone fusion to reinforce the hardware, in these patients we're throwing everything plus the kitchen sink, and 90% of the stuff we were leaving behind was vaporizing, and practically almost nothing was staying behind to reinforce the hardware. The other thing was the hardware profile. People were putting those big Volvo headrests in guys with standard cranial-cervical instability without EDS, and they were not complaining, but the people with EDS were complaining a lot. We were calling it the princess and the pea complex. And then all the comorbidities we're going to see further. So all this, we learned over the course of the following years that we had to adapt what we were doing to this beast, the EDS / Chiari, the EDS / craniocervical instability, the EDS, whatever we had to put afterwards, in functional EDS, which was creating a more dynamic and different scenario. Obviously, if you have lousy joints, the lousy joints go up and down the spine. Why the spine? Because the spine is what we care about as neurosurgeons and neurologists. So you can have segmental kyphosis, instability, and that's a long list. You can have more disc herniations because your joints suck. You can have subluxations because your joints suck. Anterolisthesis, which means that your bones flip, slide forward in reference to the bones below, or retrolisthesis slides backwards because your joints suck. Arthrosis means that you have an accelerated wear and tear, aging of the spinal joints. When somebody moves, if a joint is supposed to move 90 degrees, but the people with EDS, they can move 180 degrees, and then they do all the party tricks they do to show off, because so they do. At that point, that joint is going to be aging much faster than the rest of the body. So after a while, they're going to have the joint of when they're going to be 50, it's going to have the joint of a 70-year-old guy. Postural anomalies, very, very often you have scoliosis or reversal of the lordosis. Practically all the normal natural curves in the spine should have in order to maintain the balance, they go down the drains because of this instability. And then the problem with the next level disease. Once you fuse a segment of somebody with or without EDS, you create two bones out of you create one bone out of what before was two independent bones with a joint in between. And obviously, if you fuse 3 segments, 4 segments, you understand the concept. The issue is that segment is good, but now the joints above and below are getting an additional stress, which most of the time doesn't create any problem, but sometimes create the so-called next level disease, which means that joint above or below starts degenerating, falling apart, and eventually you have to address it surgically. The next level disease in people with EDS is through the roof in terms of incidence. So what we have learned, again, the hard way, everybody who's involved with EDS, orthopedic surgeons and neurosurgeons, is that to do the opposite what we were trained for standard spine. You fuse as late as you can, as short as you can. Then there are also some complex concepts about where you do it a little bit longer, whatever, but this is just a synthesis, so I'm not going to go in that level of detail. Pterygoid syndrome you have heard this morning, but you have heard this morning from a pediatric standpoint. Why pediatric standpoint? Because the majority of our pediatric neurosurgical colleagues, they see the cases which are really messed up. The more messed up the case anatomically, the more the patient is going to be sick because of that at the early age, and fine, they're going to operate and whatever. Once EDS is involved, is a disease of adult people, totally different. They find the fallon terminale we're going to see in a second, which is very thick and has fat in it, whatever. Here, the opposite. very thin. So what we see here? The phylum is made of the defective connective tissue. What's a phylum? The phylum is a small connective tissue band which bridges the end of the spinal cord to the end of the spine, which is practically your tailbone. And it's not a nerve, it's just a piece of connective tissue. Now, EDS gives you genetically defective connective tissue, so you have a phylum which is messed up. As it's messed up, it's not going to behave like a normal phylum. So what's going to happen is that once you are a child, it doesn't give you much in terms of problems because it's stretchy. But as soon as you start growing, it starts becoming thinner and more under tension. In order to explain, I say, imagine that you have a car and you're putting in neutral, and then you tie a big rope in the front of the car, and you can actually pull it, when you are on a flat land. But if you have a rubber band, as thick as it is, as you pull, you're not really moving the car that much because the rubber band is going to stretch and stretch and stretch. This is what happens in these patients. As you grow up, and again, most of these patients become symptomatic when they're young adults, the phylum, as you growing up, instead of stretching down the spinal cord like you would do in a standard pediatric case, stretches itself and doesn't move the cord, yet generates enough tension to the bottom part of the conus to create these symptoms. So it's a disease of its own. So a lot of the discussions that the pediatric neurosurgeons are having about each other, okay, like whatever, you have this kid with a delayed bladder training, why don't you wait 2 more years before, here we have adults who are already bladder trained for 15, 20 years, and all of a sudden they're peeing their pants for no other reason than that. So it's a different kind of fish. So the phylum, the occult tether cord, which is the tether cord in which the conus is in normal position, is higher in incidence in the EDS population. And now you understand why, because the phylum per se is so weak and stretchy and elastic that the absorbing part of the stress itself. The phylum is thin and elastic, so instead of being 2.5 millimeters of diameter, in this case it's between 0.5 and 0.9 millimeters most of the time. The patients are older, and the skeletal growth makes them worse. So we have patients who develop neurogenic bladder way after the point of not wetting the bed anymore. And the dura is see-through thin. You can read the newspaper through the dura of these patients. And again, because of the EDS component. And there is obviously a higher incidence of CSF leaks. So this is a kind of a different beast. I'm going to spend some more time on things that you guys don't know a lot about. The first one is the idiopathic intracranial hypertension. The venous circulation of the brain is quite complex. Everybody is distracted by the arteries, but the veins are as important. And how do you drain the fluid, the blood out of the brain? There are some veins which go to some major highways called the dural sinuses, then goes to the internal jugular vein, superior vena cava, and then to the heart. At any point of this circulation, you can have an occlusion. It is like an accident on the highway creating a standstill and creating a traffic jam. So a venous occlusion acts the same as when you go to the doctor and they put a tourniquet in your arm. Tourniquet in your arm is good if they want to do a bloodletting, get some blood samples, but it's not good when it stays over there and the doctor forgets and you go home with a tourniquet on. So it creates a venous congestion that after a while it creates brain swelling and creates this increased pressure, which is secondarily related to the CSF, has a repercussion on the CSF afterwards. But the first problem comes from the venous congestion. So this is kind of the anatomy of these major highways, which are kind of it's like a separation within the dura. The two leaflets of the dura open up and they create this channel. And these things are quite big. The most important ones are those which are leading directly to the main outlet, which is the internal jugular vein. And the transverse sinuses, which then become the sigmoid sinus, are very important. Now, the jugular vein on the way out has to pass through a hole, and this hole is called the internal jugular canal. or internal jugular foramen, which actually is a canal itself, as we're going to see in a little bit. Then once you go in the neck, you're going to have the superficial and then the external, the internal jugular vein, which then go to the superior vena cava. So you can have strictures at any one of these points. At any one of these points, you can have strictures which result in a venous congestion, which leads the pressure high. Obviously, the tighter the stricture in the highway with the highest amount of traffic, the biggest effect anatomically and clinically. So you can have a stenosis, which means a stricture, and that's the equivalent of closing down 4 out of the 5 lanes of a highway. So traffic is a traffic congestion. But sometimes you can have a collapse. Now, the walls of these big sinuses are made of connective tissue, and here we have a connective tissue which is defective because you guys were born that way. So instead, they behave very often, not they're collapsed, not that they're stenotic, like you would have a plaque in the carotid and the lumen becomes smaller, but they collapse on itself. You remember the Capri Sun packets? You put the straw inside and then you suck and the pack collapses on itself. That's what happens often on this, and especially when you change position. They collapse on itself and then often they stay collapsed. So they need something to pry them open. But often they're stenotic because of thrombosis or sometimes congenital. Then you can have the stenosis of the jugular foramen. And this is a problem because the jugular vein passes out of the skull through a bone canal. And sometimes because of abnormalities of the formation of the skull, this hole, instead of being large and comfy for the jugular vein to pass through, chokes it up. And this was something that Mira, Dr. Kula, and I have seen in patients with Chiari Malformation on 3D CTs back in the late 90s. So it's nothing anything new. Then you can also have a stenosis in internal jugular vein, and as you're going to see also by some anatomical process. So treatment, what you do about it. You can put a stent, you can shunt, or you can do something creative. The stent, you can see it here, is not done by surgeons, it's done by interventional radiologists. And you're coming from the groin, you're floating a catheter, then this catheter has a little spring-loaded mechanism which opens up like an umbrella. You would open up an umbrella and keeps the lumen open. And you see the before and after is quite dramatic, before, after, and this is the way that a stent looks in 3D CT. The jugular foramen is a bigger technical problem because many stenosis happen here, and we saw this as a problem when we're treating tumors. There are some special tumors which grow here, so you're inside the canal. The canal is comfy for the vein, but if the tumor grows, it eats up the breathing room, so the vein gets collapsed. But imagine that the bone per se is not big enough for the vein and is kind of as a choker. At that point, you can have a stenosis you cannot really fix. There is no stent. The strongest stent in the world cannot dilate and break the skull to make more space. So this, for now, is still a technical, uncorrectable problem. Then the cases that you cannot stent or the stent is not enough, you shunt them. In the past, we did not know better. We were shunting everybody because there was no stenting. And then the first case of stenting was about 10 years ago at the institution of Dr. Recate. That was Dr. Albuquerque did the very first ones. So back then we were doing the shunt, and again, same problem of you're throwing a known variable, a known entity to a thing that you barely understand. And the thing was, we have high pressure. If you take out CSF, patient feels better, take a shunt. And then what we didn't realize that the shunt hardware we were having was designed for hydrocephalus. It was not designed for these things. The ventricles were small and they're not big. The lumboperitoneal shunts do not work well, especially if you have a low-lying tonsil and other things. So bottom line, after a while, we realized after the eggs on the face that we had to adjust our problem. Again, you realize afterwards. Fortunately, the stenting came on the way. So right now, stenting are not indicated for children for now, so it's 18 and above for stenting. But everybody else who's not helped by the stent or not helped enough, there is the shunt. Shunt can be VP shunt, LP shunt, I'm not going to go into detail. But then, and the LP shunt is over here on the left. Then there is another version. You do not need to shunt a lot for these patients to feel better. So practically pretty much at the same time, 10 years ago, us at the Chiari Institute and Dr. Frame at the University of Chicago were working on the principle of the Omaya. The Omaya is a dead-end catheter going to a plastic bubble which is underneath the skin, and is used to inject special drugs in people who need, for example, chemotherapy and stuff like that. And that's going in. So we're thinking about using this process about sucking fluid out in order to give the patient the opportunity, or their physician, to do intermittent lumbar punctures. Obviously, we were not putting it here in the skull because the ventricles was barely bigger than the catheter. We're using different kind of approaches, but we had problems with the hardware. So for now, the idea is still good, but is not viable yet. We have to work with the industry for it. But again, this is the exception of the exception. Whatever majority of the people are helped by the stenting, then the few people are going to help with the shunts. Whatever doesn't work with the shunt, or the shunt is not adequate, is going to be a sort of a backup of a backup plan. The jugular sometimes is compressed in the neck by something called the styloid process. The styloids are supposed two little very short matchsticks attached to the bottom of the below your ear and converging towards your voice box. Sometimes in this patient become enormous, they become like the size of fangs or elephant tusks. And in a number of cases, we identified that the jugular vein often gets pinched between the back part of these fangs and the lateral anterior part of C1. And this pinch sometimes can be stented, but sometimes cannot. So the thing you have to do is to remove this fang called the styloid process. We found so far 95 patients with the styloid hypertrophy in the EDS population out of just our patient population, which has been fused with craniocervical fusion. So there are a lot. And the increased association between Chiari and styloid process has already been published by Mirot in 2007. Treatment. First of all, you have to diagnose. Okay, I'm finished with the increased pressure. Now we go to the opposite, which is the hepatic intracranial. Sorry. No. This is still the hypertension. I had a brain fart moment. There are some problems, like how do you diagnose it? The decision-making tree for the treatment is still fluid, as you know. Like a few years ago, we're still just shunting. Now we do the stenting. How you do the diagnostic, we do the entry level, then you go higher up, we're still refining it. How you decide where to do the right turn or the left turn in decision-making tree. What are the qualifying criteria for each level of the treatment? And then, major problem here for the stenting, what's the long-term outcome? The oldest stenting which has been out there is no older than 10 years. So we do not know if these stents are going to stay there for 20, 30 years open, or they're going to create more problems later on. So it's still open for us to find out the hard way or the good way. Opposite end of the spectrum, intracranial hypotension, very frequent in the EDS population. So the pressure in our nervous system is dictated by the sum of three ingredients: the nervous tissue, the blood, which supplies it, and the CSF, which is bathing it. You have an intracranial and interspinal compartment, and you have changes of pressures and volumes when you change position, and you have the top and the bottom, and above and below the heart as a reference. How can you develop low pressure? You can lose pressure by leaking or by having a so-called abnormal dural compliance. So how do we explain in simple words? You have a leaky plastic bottle, and the plastic bottle has holes in it, and at the point you're leaking, you're not going to have the same volume of water inside your bottle by the end. Or you can have an abnormal container. There is nothing wrong with the content, which is the blood. If your veins in your legs, everybody knows varicose veins, become much larger because of some pathological thing, whenever you get up in a hot day on the beach, half of your blood supply of your blood content is going to be trapped in your legs, and you're going to feel dizzy. So the problem is either you have holes and you leak, or your dura is too stretchy, and the dura is made of connective tissue, and guess what happens? So there are certain parts of the dural box, dural container, which are more subject to stretch because of pressure, and those are generally to be in the lower part of your spine. Leaking points. So if we focus on the bottle having the holes, where are these holes? You can have persistent holes after lumbar puncture. After lumbar puncture, you make a hole in the dura, and hole in the skin and hole in the muscle, and when you remove the needle, your hole is going to close progressively because that's the elasticity of the tissue. But if your tissue has a poor elasticity, that hole stays open for 15 days, sometimes 2 months, sometimes 3 months, sometimes 6 months, sometimes more. So lumbar puncture in EDS patients creates persistent holes, which sometimes persist for years. You can have iatrogenic lumbar pseudomeningoceles. When there's a lot of Greek words together, the doctors are playing a trick on you. Iatrogenic lumbar pseudomeningoceles means the doctor has messed up. So didn't close the dura well, and is leaking like a sieve, and at that point creating a fluid pocket there. But I messed up, and you have a fluid pocket, doesn't sound very well in academic. Dural blebs, we're going to see them in a second. Because of pressure and the dura not being able to bear that pressure, you create these small balloons of ballooning of structures of dura that become thinner and thinner and eventually burst. And then the Tarlov cyst, which are a little bit complex to be explained, so I'm going to glass on it. This is in the spine and the spinal cord and the dura surrounding it. Needless to say, at regular intervals, there are some like branches of a tree. There are nerve roots coming out, which are surrounded by dura. And this is where the dura is the most vulnerable to create little balloons, very, very small, like 1, 2, sometimes 3 millimeters in diameter. They then become so thin, and then they burst. And then they give a lot of CSF leaking out. But it's just a few cc's that create a vacuum effect, which makes you sick. Scenarios. You can have a normal pressure going too low when you leak, or whatever happens to you. Or you can go have a high pressure, the hypertension before, that then when you leak, first goes down to normal, so you feel hell of a headache, pressure headache, and then you feel a little bit better. And then a few days later, worse, a few days later, you feel horrible because now you have low pressure headache for your leak. Then the leak gets repaired, or Mother Nature does it, and you go back to normal, back to high, and you go in a loop. Dr. Recate was always very, colorful in his description. He was calling it the whack-a-mole scenario, because you create a little blab of defective dura in one area, it bursts, then from the high pressure become normal, then becomes low, then somebody fixes it or Mother Nature fixes it, and then the pressure goes back up. And once it goes up, it stretches the dura again in another area of the nervous system. And like a whack-a-mole, you're always checking the last one. You whack it, and another one pops up. The guy here is the messiah of intracranial hypertension. He's Dr. Shevink from Cedars-Sinai. He's the guy who has dedicated the most of his time in his career about it. He has written many different articles, and very early when he was playing and we were playing, we discovered we had a lot of patients in common, and these patients all had Ehlers-Danlos syndrome. So this is one of the things. So we exchange patients all the time. Treatment: blood patches, glue patches, surgical patching, and surgical dural corset. The concept of the blood patch is the same one of the Dutch boy putting the finger in the dike. You inject some blood that they get out of your forearm in the neighborhood where the leak is happening, as you found out from other non-invasive studies, and the blood kind of tamponates and gives the time to Mother Nature to close it up. Usually they inject 30 cc's. Most of it gets reabsorbed because it's like an hematoma which gets reabsorbed. So in order to have something more permanent, sometimes they use, like they show here in this MR myelogram, they use a glue, and sometimes it's glue by itself or glue mixed with blood or any kind of mix that they come up with. The glue is a little bit, it doesn't take a lot, it takes less volume and tends to be a little bit more long-term effective. Now, obviously we're still trying to figure out what are the qualifying criteria for one step, the qualifying criteria for the other step, how much you should inject, how many levels at the same time is safe to inject, and blah, blah, blah. And again, is the same concept of we are adopting something which is a known variable to an unknown scenarios. Therefore, we will expect both the doctors who are trying to treat these situations and the patient themselves, we're going to end up with some X on the face in the process. But eventually we're going to get there. The point is, you remember the varicose veins. Varicose veins scenario doesn't have any leakage. So how do you repair it? So Dr. Shevink and I came up with the same concept in two different executions. Dr. Shevink does a laminectomy over 3 or 4 segments, and then like you go to the tailor and they tuck in your tissue. He does a sort of a stitching like this over, not a bit, like a snug stitching over a long tract. I do generally a laminotomy, so a short end, and I do a much tighter, not stitching because that I saw they did not work, but do a corset. It is like those corsets from the 1900s, and the women were having that very narrow waist, and you put it with Gore-Tex, which is non-extendable, therefore it's not going to have the effect. Again, for this, we know it works well short term, but we do not know how this is going to work over a course of 10 years, etc. Mast cell activation disorder is something which has a higher incidence in the EDS population. Why? Because connective tissue is also making the everything which is in the inflammatory response. And this is very important. The mast cells are an important brick in that wall. Allergic reactions are the mainstay. Medication allergies, side effects are a big pain in the neck for the treatment of these patients, and rashes. Mast cells interact with practically everything plus their cousins, and they have a lot of interactions, chemical interactions with a lot of cells, tissues, and chemical components. The effects, they practically affect every system from cardiovascular to skin, gastrointestinal, hormonal. And you can have very drastic situations which lead to the patient living with their EpiPen constantly and a mask, because just to have some smells trigger these massive rashes and hypotensions in this autonomic crisis. Closing up, the term trifecta, which comes from betting on horses, was introduced by a patient of ours back in 2005, when we were starting seeing patients who were having Chiari, Cervical Instability, and Tethered. And very soon we discovered that, like for example in the case of the Sarah syndrome, where they were also having dysautonomia, and very often they were also having mast cell. So the EDS exposure to all these combinations, which not only are tricky to treat surgically, but they're also a nightmare from a standpoint of medical treatment during the hospital and beyond. Thank you.